Hi, this is Judy Saalinger from Lasting Recovery, San Diego's premier outpatient alcohol and drug treatment center. And today we're talking about
living with an addiction, living in recovery, is a hard job. One of my heroes in literature, let's go ahead, is Sisyphus. He doesn't ever give up. BMT makes the rock a little smaller. Living in the world, if you've developed an addiction, is a challenge. It's hard. And as Judy and I were talking today about a troubled young woman we have at Lasting Recovery right now, essentially what I wanted to do by treating her opiate dependence with buprenorphine is allow us to work on her other 7 problems. Right? I just want to pick the low-hanging fruit, so to say. Because getting a life means you have to figure out how to cope with relationships and stress and, do all kinds of things that are hard. And if you've got this dog barking in your brain all the time, it's much harder to do that. So we hope to go from that to this. This lady says, "Can't you ever relax?" And give Sisyphus a little relief. Just a metaphor for what buprenorphine maintenance does. So if it just is pictorially, here's your opiate receptor. Mother Nature made these. They have a good function. Here's an opiate like Vicodin. And then here's buprenorphine, our little guy. And when this is empty, you get pain. And pain isn't just physical pain. Pain is activity in the limbic system, emotions, all kinds of nasty, toxic stuff. You probably get norepinephrine released, which makes good stress memories, right? Because before buprenorphine, if any of you were trapped on a desert island withdrawing from opiates and no buprenorphine, what drug would you want? Desert island withdrawing from opiates. I might choose, Christy, I would choose clonidine. That would be my drug, one of my things to take the edge off, right? So noradrenaline gets released in this process too and makes these memories. And it's possible that cycle of withdrawal, noradrenaline, awful, opiate, feel better, it's possible that cycle just burns a hole in the brain. Your stress system permanently changes your stress system. So this is a full opiate block, right? This turns the receptor on, no pain, euphoria, feels good. Next slide. Buprenorphine is a partial blocker, kind of does a little bit of this. And then these guys can't get on board. It's a nice pictorial representation. It's an imperfect fit. Next. And even as buprenorphine, because it's got it stays there a while, and it sticks hard, remember? So then even as this dissolves, these guys still can't get access. Next. And so this is just a picture of the cycle. So this is kind of what you can have in your brain, what this drug is doing in the brain. This is another critical study. I talked about this with a patient last night who's now in recovery 4.5 years for the first time in a long time, let me just say. Still on a low dose of buprenorphine. This is a study in China. I don't know how they recruited these patients. These are all heroin addicts. They selected them based on different time in recovery. 1 week, 1 month, 15 days, 30 days, 90 days, 12 months, and 2 years. Okay? Now I'm going to give all of these folks a decision task, which involves making decisions. Like, do I do this? Do I not do this? A good idea, not a good idea. Okay? Now, at the start of it, so this is the task. Low scores are bad. You flunk the test. High scores are good. At the beginning of the test, you'll see that comparison subjects, not opiate dependent, and let's say the 2 year, abstinent folks look the same. Now, I'm going to stress you out. I'm going to make you, thanks Art for the reminder, I'm going to make you talk in front of people. So they take these addicts and they ask them to talk in front of people, stress them out. And actually the task they do is they have to subtract 13 from 100, and then if they get it wrong, they say wrong, and it stresses people out. Okay? Yeah, that's what being a scientist is, right? You torture people. So once they're stressed, guess what the 2-year sober people's decision-making looks like? This is kind of part of the point why I am arguing that some patients really need chronic treatment, because you can look really good when you're good, and when you activate those stress systems, your decision-making goes back to baseline. Very powerful. Now let's look at the next slide. What can you do to help these folks? What's interesting, this drug, propranolol, blocks adrenaline in the brain, and that helped. I won't get into the complications, but if you give folks propranolol and do the same thing, their decision-making doesn't get quite so bad. So there's something about this that's about stress systems. So even if you're a year out and you get stressed, My concern is part of being in recovery from addiction is that when you're under pressure, when you're stressed, that your decision making can go right back. The brain just goes right back. To me, that's worrisome. Next slide. So there's a few buprenorphine preparations, Subutex, Suboxone. Just go ahead and roll through these. These are Schedule 3. I can call them in. Here's the typical doses. And Buprenorphine is approved for analgesia. Some pain doctors argue that we should make this first line for pain. Chronic pain, because if you're going to give them one, might as well give them this one. Rapid onset, 20 to 60 minutes after a sublingual dose. Remember, they put it under the tongue. It goes directly into the bloodstream. Peak effect is 1 to 4 hours. Duration of action depends on dose. Another take-home, now we're going to bridge into talking about buprenorphine specifically. Another take-home is, for chronic buprenorphine maintenance, dose effects are very powerful. If you want a summary of all of this, send me an email. I'll send you an article. And the elimination half-life is about 24 to 36 hours of buprenorphine. So it stays around a while, which is nice. Once people get stabilized on this, anybody heard a patient say, you know, I missed a dose or two, didn't really notice? Kind of nice, right? Because then you're not always, right? Part of what it does is frees you from mental compulsion. That's what I talk about with patients next. So buprenorphine is a substitute for opiates, so it prevents withdrawal. It can be used for maintenance, reduces illicit opiate use. The long duration of action means you can dose it daily. And the side effects are similar to opiates, but it's less sedating and safer in overdose. Remember the slide I showed you with full opiate stimulators can depress respirations. Buprenorphine tends not to. And so this is just a differential diagnosis of drug taking, of problems with drug taking. Addiction, which is out of control compulsive drug use, but pseudo-addiction, some people don't really meet. We've all seen the pain patient who kind of chases their tail. Then there's other diagnoses. It's not clear, you know, a high percentage of patients with addiction have personality disorders, which I think are often well treated in some kind of chronic therapeutic model. Chemical coping, depression, anxiety, and then criminal intent diversion. These are some things that cause this aberrant drug taking. Next, we have, if anybody wants a little algorithm for deciding about buprenorphine maintenance, I just made one up because we didn't have one. But essentially, it's a kind of like any comprehensive psychosocial evaluation. You know, we don't want to put large amounts of a drug with street value in the hands of somebody who's not a good candidate. But failing multiple other treatments is an indication. So there's a lot of, go ahead and advance. This is the marriage of Sisyphus. Relationships can be challenging, right, in recovery. Go ahead, next one. Patient selection. There are some other things we should keep our minds for. We'll probably routinely test for HIV, hepatitis, other use of, this is a relative contraindication. You know, if you're going to die from buprenorphine, what it looks like is if you take it with other sedatives, no surprise. So somebody who has comorbid other addiction. Pregnancy. Current data, 2014, best data. If you got a heroin addict who's pregnant, buprenorphine's probably one of the best treatments. This is obviously an evolving field because nobody's doing a trial in this, but that's probably one of the best. I saw a woman 2 days ago who her child is now 2.5, and she was in the midst of it and took buprenorphine through her pregnancy, and the little one's doing fine. Again, that's an anecdote, but what else are you going to do with these poor patients? Next. So that's pregnancy. Gets easier the second time. So here's let's just talk about decision making in buprenorphine. We're irrational mammals at our baseline, even if you don't have dependence. This has been shown by studies of something called loss aversion. We're more scared to lose $6, right, than to not make $6, even though the net sum is the same. Confirmation bias. We seek data for things we believe and discard data, right? These are cognitive errors we all make. We have framing effects. I can give you a decision to make, and if I frame it a certain way, you'll go one way, and if I frame it another way, you'll go another way. It's the same data. We're irrational mammals. And anecdotes, I'm subject to this. If I have a patient who just had an awful side effect, I'm less likely to prescribe that medicine, even though the statistic hasn't changed. So we're irrational mammals at baseline. People with addiction have something on top of that. They have difficulty thinking in the medium to long term. This is part of their state. They're uncomfortable, and probably part of a trait. So how in the world can patients with addiction rationally evaluate the reality that they have a chronic long-term disorder and evaluate the risks and benefits of things down the road? It's hard. So there's a recent article in one of the top medical journals talking about the fact that as providers, we should, of course, engage in collaborative decision making. But when there's clear data for something, we should inveigh toward that. It's not just simply, what do you want to do? Because your decision maker is obviously as good as mine is, and then let's let you do that. What kind of illness is opiate dependence? It's an illness where people make short-term bad decisions and don't think about the long-term. So discussing treatment options should encompass these factors. Next. This lady's name is Justitia, and she's the goddess of justice. She weighs risks and benefits. So when you're talking with patients about treatments for anything, we're always weighing risks and benefits. One of the risks of opiate dependence is what? Worst risk, death. Okay, so death is on the scale. Okay, so anything that doesn't cause death gets to go on the other side. So when I'm talking with people with opiate dependency, sometimes you got to square them around to what we're talking about, right? It's a little bit like an unfortunate patient I saw in the inpatient psychiatric unit who had a lot of distress and was thinking about, you know, jumping off a bridge, but maybe didn't want to take a medicine because it might cause her a rash. You know, you think this is just kind of interesting decision making.